Welcome to AFMC TV. I'm Robin Linder.
The goal of that is to maximize people's quality of life, right?
You want to make sure that your housing is affordable in your community.
We have to think about vaccines in a way that we haven't thought about them before.
I had a lot of religious adults who were very creative.
Down on the floor and play with their kids.
AFMC TV, thanks for watching. Have a great day. Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. I have with me two special guests today, Dr. Rashida Bagchi. She's an assistant professor of physiology and cell biology at UAMS. Thank you so much for being here, Dr. Bagchi.
Thank you.
And Samaya Ibrahim, who's a pharmacology PhD candidate and are part of the research team. Thanks for being here.
Thank you for having us.
So we're talking about metabolic obesity. Tell us, what are the key biological metabolic factors driving obesity in rural Arkansas? That's a part of what you all are studying.
That's correct. It's interesting you bring that up because when you talk about obesity, and it's not just in Arkansas, but the country worldwide, it's a global epidemic. That's what we've been seeing. And the real issue with that is not just somebody putting on weight. That's not the real issue. That is basically what we get into then called the metabolic syndrome. So when you talk metabolic obesity, obesity is just a facet of that. So metabolic syndrome is the big umbrella. And that's what we work on too. That's the big umbrella program we run in our lab too. And I think my student will also agree, it's not just those numbers on a scale that you see when you get up in the morning and you're like, oh no, it's about, that excess energy that you've been consuming, and every single person is different. We got to keep that in mind, how it's being used in your body and how much of it is stored and where it is stored. So that's what it comes down to. And then when you start storing that excess energy and you're not able to use it, we have very fine terms for that. One of the terms is insulin resistance. What that means is your body does not have enough capacity to fight that excess sugar or process that excess sugar. If you go to a clinic, they'll tell you you're either pre-diabetic, so you're on the onset of diabetes, or you actually have diabetes. And that's basically what insulin resistance is. There have been phenomenal studies done, and people are still continuing to do that in the clinic, about where this extra fat accumulates in your body. It's usually in our belly. That's where the fat goes and sits. Men, women, all of them, right? And when we do our studies also in mice, it's the same place. So there are some things that are similar. They wrote this book called Of Mice and Men, or Men and Mice, but there are similarities. Women are also included in that, so we should keep that in mind. And then when you have this extra lipid and glucose, what do you do with that? Your body is not used to handling these things. So, that's again part of metabolic syndrome. You have too much lipids in there. We call it hypercholesterolemia, right? And then you're predisposing yourself to have a lot of these deposits in your blood vessels. Eventually they cause heart attacks. So that's again, this happens over time. Plaques will start building up since you're born. That's just a normal process of your body. But there are these external factors also that can make things worse. So all of these do come under metabolic syndrome. Let's not forget there's genetics also. We cannot control that. You and I, we're just predisposed to some things, based on what we've got since we were born. So we really can't control those things. And then when you talk about specifically of rural Arkansas, you see this pathophysiology everywhere. So not just one or two things, but more than two together, which qualifies them to be a patient suffering from metabolic syndrome. That's what it comes down to. Overall, that's, like I said, that's the bigger umbrella research program that we run at UMS.
So it is different than, say, traditional obesity. Far different.
Yeah. And what we study in our lab is the early hours, like the first few days in humans, or in mice, we study the very first few hours and see what happens and what changes we see. So we see increased inflammation. We also see mitochondrial dysfunction, insulin signaling that changes. And this is very important because all of us have a different BMI, but all of us have different cardiometabolic risks associated with that. It changes between person to person. This is also important clinically because we have to watch out for not only just weight, but we also have to look at other metabolic risks. And that includes lipid accumulation, glycemia, hypertension. And then for rural Arkansas, all of that is increased the amount of people that are consuming high nutrients is a lot in rural Arkansas. So this is even more important in this area because it can accelerate the risk of ending up with hypertension, diabetes, and also heart disease.
So from your research at UAMS, what rural-specific factors, is it access to food, transportation, or even healthcare that really contribute to metabolic obesity?
Yeah, so there is a lot of lack of transportation, isolated communities that can't access healthcare as easily as other places that are more populated, where there's more hospitals. All of that causes stress on a patient. So, and that stress causes all of these pathways to become activated, leading to increased stressors, which cause the fat accumulation, and mostly it'll be like visceral in that belly region. This could lead to other dysfunction. It can also lead to mental health problems.
Correct.
And those problems could lead to sleep deprivation, and sleep deprivation in itself is a stressor. So if we work on helping out these communities with finding them transportation, with sleep management, we can reduce that risk for them and help them become a lot more healthier.
Interesting. It's like multiple things, not just one. That's really detrimental.
Yeah, and I would just like to give a shout out basically to people in the lab and the stuff that we do, especially to Somaya. She actually currently is leading a couple of studies where we talk about acute nutrient overload. So you think like, oh, you're accumulating fat over a period of time. That's correct. When you're at the clinic, you're at the point where you need treatment. So our goal has been to see, are there ways we can find early triggers? So then you're at a point where, well, maybe we can take steps for prevention or slow down the disease progression, rather than being at a point where you can only treat the symptoms but not reverse what is going on. So what specifically Somaya has been doing in the lab is we generate heart cells, fat cells, all of these liver cells, they're called hepatocytes, from patient-derived stem cells, right? So you can have these cells, and we have like collaborations all over the country. We get these like cells from patients. They're this like stem state, which is how most of your cells are when you're developing, right? So we can go back to that, and now you can tune them into any cell you want. So what we do is we end up deriving different kinds of heart cells, and Somaya bringing her engineering degree, right, biomedical engineering degree, into practice, which was phenomenal. I got lucky with that. We can actually 3D print these miniature hearts that beat. So we're basically making these mini hearts in a dish. And this is not just at UMS, this is very unique to the state of Arkansas. So we're hoping through this, we get more people to know about it, because we can mimic any cardiometabolic disease aspect that you can think of. And it's not just like, we see something in mice models. Well, it might not completely translate to humans. So we have this very robust human system in our hands that we can now use. And you say, oh, maybe there are certain drugs, that can be put in patients. Well, we can't put them in patients directly, but we can test them out. We can look at, things at the molecular level. We can see how fast they beat, how slow they beat. If they're beating fast, can we slow down the beating rate? And we've actually made these to the point, like they can recapitulate how the human heart beats. So like around 60 to 70 beats per minute, which is phenomenal. They handle ions the same way. So all these assays have been done. So I'm really proud of where we are, and thanks to her. And that's why I'm really liking that she's willing to stay for her PhD with me. And that's just like translation, and that's what we want. We have questions in our mind, and we work very closely with clinicians and cardiologists, because they are the ones who see what is happening at the bedside, right? And we're like, tell us what the actual problems are. And we're like, okay, how can we bring it to our bench, come up with answers so that you can now bring it to your patients? So it's a two-way street, and that's what I think biomedical research and healthcare, once they come together, that's the ideal scenario.
And you touch a little bit about, we focus specifically on rural communities and how does social determinants of health play into this? And we talk a lot with healthcare providers about how they use that to help determine a practice of care. Does that play into your work as well?
Yes, of course, all of that plays into effect because we take what we see and we can try to recreate that in our models. A lot of it can be done in mice, but also we can do it in humans, like what she said. And we can introduce some of those stressors into what we're working on to better understand all of these mechanisms that happen.
Yeah, for example, like the fat accumulation, right? We get this, we call it cocktails, of course. Not the ones you would find at a bar, but in a way they are. We put in like cytokines. So these are like signaling molecules or things like cortisol that your body makes a lot when you're under stress, right? So you can take these like mix of fatty acids, which is in your food. Some of these actually go up right away when you ingest food. So we take some of those, throw in some cortisol, some other hormones, which your body will naturally make when you're ingesting food. And then we can do that in a dish now. So we are mimicking this like, acute nutrient overload. Now you add this like cortisol and stuff. You've now induced stress also, right? So it's not just that. You want diabetes, you put in a higher glucose amount in that. So that now mimics diabetes also. So we definitely are at a point where we can start doing a lot more, going from animals to humans to community studies, because at the end of the day, I keep reminding myself why I'm in biomedical research, right? And anybody who walks through the lab, we get high school students coming to the lab too, right? And they're like, why do you want to do this? Well, they want to just have fun, but then they also realize, they go and present. I'm like, think of what this is going to do for somebody in long term. It's going to help some patient. It will not help them today, tomorrow, 10 years from now. You know what? That's when I'll be like, I think I did a good job. And that's the satisfaction you get out of research.
And this ties into social determinants because whenever in like rural Arkansas, you can't get access to a lot of healthy options. It's just a low amount of healthy options out there. So having that overload that we induce, the nutrient overload, it's similar to as if you were going to fast food, which is very common whenever you have to do long drives and that's your only option out there. So it mimics that, and it mimics the high sugar overload too, where you're drinking excessive amounts of soda or you're drinking a lot of like maybe energy drinks, depending on what the person likes to do. So that ties in a lot of what we do.
So interesting. What trends are you seeing in cardiometabolic conditions like diabetes, hypertension, as well among rural Arkansans?
Okay, I think I'm going to take that because I did some analysis, and this is not AI based, I promise. This is actually going into American Diabetes Association, looking stuff up there, Arkansas Health and all of that. So from what I got, and this, I think the report is from a year or max 2 years ago, which is not bad at all. We're catching up to this year. What we got is about 13% of the adult population in Arkansas definitely has diabetes. So this is diagnosed diabetes we are talking about. And the way you do that, at least one of the factors is hemoglobin A1C. So if your doctor says, oh, your A1C is more than 6.5, which actually is pretty high, that's, you've just crossed into the diabetes, gang, I would say. Less than 6.5, they'll be like, oh, you're pre-diabetic and all of that, but it's not that great either. And then there are about 35% of people here that are close to being diabetic. So if you remember, initially I said, oh, you could be pre-diabetic. So you're almost on the cusp of that, which is not great. And then when you talk about, add that to the hypertension, right? You're talking more than 40%.
Wow.
Of people in Arkansas have hypertension, diagnosed or undiagnosed. And it starts very small, because like, can I take 5 steps? Can I take the stairs? Yeah, fine. Can I do 10? Maybe. 12? I'm pushing it. Is that hypertension? I don't know, but it's time to go get it checked out. But again, going back to, rural Arkansas, do we actually have those facilities? Can we have some screening camps there? these med students, can they go out there just for a day, right? Go in with blood pressure monitors, just sit down with people, talk to them, and analyze what is going on. I think we need that kind of hands-on approach because we can do all we want in the labs, right? In our research, but we need that connection with the community as well. So, but what this eventually will do, if you have high diabetes, high hypertension, you're basically like not just doubling, but maybe 5 times or 10 times increasing the risk of heart disease and stroke. So let's not forget, this is also part of your vascular system, right? So you have tubes running, which carry blood all throughout. You start blocking them, well, you're killing the cells there. Stroke, we've seen what happens to people. Heart disease, if you're lucky, you'll live or you're dead. And then what, right? So the whole point of the work we do and what I have always envisioned is like, let's try to find things early on. I have lost family because of heart disease. Very closely, and that's why I studied a lot about it. I did not know how important it was, but when I started losing family, subconsciously somewhere I was like, I need to know more. So when I jumped into my PhD, serendipitously in Canada, that lab was studying cardiovascular disease. I had no background in that, but my PhD mentor, who actually Sumaya also met recently at a conference, he just said, he's like, if you want to learn, I will teach. And that's my motto too. And why not? If I have not been able to learn something, doesn't mean you shouldn't either, right? So, and I think this community-based approach is somewhere where we can learn so much from the community. Like talking to you, people in Arkansas, like, if even 2 people listen to us and be like, hey, I think that's interesting, we should get in touch. We'll be happy to talk to you. So bring us your problems and let's figure out ways we can give back to the community.
Really groundbreaking research that's happening right here.
Yeah, absolutely. We think so. Yeah. We just hope the funding agencies also think so.
Well, I hope so too. So before we go, if you could leave our viewers with one key insight about the real drivers of metabolic obesity, what would it be?
So I'm going to just say a line or two and then I'll let Sumaya wrap that up, because that also helps her practice for, doing more thesis related presentations also. But in simple terms, like we started, when your body, gets exposed to this sudden nutrient surges, right? So it's like an acute overload, right? Or poor sleep, because you have to drive somewhere far to get things. You stress out a lot more. So all these together, your body starts adapting in very strange ways to this inflammation, a fancy word for a lot of things going out of order, right? Insulin resistance. So your body's not able to handle this sudden surge of glucose. But somehow our bodies are unique. Nature is unique because it starts thinking that's your new normal, which is unfortunate, right? How do we go after that?
Thanks to advanced research, we can work on reducing the dysfunction early on and catching those triggers early. This means reducing stress, controlling glycemia, controlling all the nutrient overload. This is very important in rural Arkansas because we can help those patients go from being unhealthy to healthy early on without them having to go into heart failure or anything severe. So if we catch these warning signs early, we can reduce all of those factors from breaking our body down.
Well, thank you both for sharing, giving us an insight to this study, this research that will have life-changing implications for Arkansas. And I appreciate you both being here today. Thank you so much for sharing.
Thank you for having us.
Thank you.
Thank you.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.